It's lovely to see you here, and it's nice to give you some of my experience as an epidemiologist. I'm going to give you an overview of how epidemiology helps to identify health priorities. And I thought if we have some time, I might tell you what sort of epidemiology I do, because there are many different types. I mainly work in hospitals doing hospital-acquired infection, so cross-infection, trying to spot the reason why it happens to prevent it from happening again. I've also done work in SARS, so the SARS outbreak in Beijing, and in a hospital, the SARS designated hospital in Hong Kong. And how I use epidemiological approaches and those principles to try to work out where the source was coming from in Beijing, and also why healthcare workers were getting infected. So I was using very, very basic tools of the epidemiologist, but they're still very powerful. So let's start. First of all, let's talk about epidemiology in the wider community and how you will be taught about how to identify health priorities in Australia using epidemiology. So that the role of epidemiology, if you got a whole room full of epidemiologists, we'd all argue about the very, very finer points about what is epidemiology. However, everybody would agree that it looks at the frequency of diseases, tries to look at causality, but not always, because there are some very important roles of epidemiology that just look at how much, just the magnitude. Not does X cause Y, but just the magnitude. So here I've listed it describes a health problem. It can test the association between a factor and a health problem. So smoking and lung cancer, for example. So it can't actually ever tell you that smoking causes lung cancer, but it will tell you statistically that there's a high likelihood of smokers getting lung cancer versus non-smokers. It can also be used to test interventions and screening in the wider community. Does anybody have any examples of testing in the community? So testing for a disease.
Is it like mammograms?
Exactly.
Breast cancer?
Yeah, exactly. So the reasons why those programs came about was because of the epidemiological evidence that supported the idea that the earlier we find breast cancer in certain groups of women, the more likelihood there is that the treatment will increase their longevity and help save them from breast cancer. And so epidemiology, apart from looking at that association, like the second point, it can also then be rolled out and tested as well. So the epidemiological tools that we use can be as simple as a surveillance. So it looks at how much there is, and it continues along forever, like how much HIV there is. Now, it won't necessarily tell you that men having sex with men or injecting drug use causes HIV, but it will tell you which groups have the greater burden and are more representative of the disease, of the new cases, so that they can then roll out programs to inform risk groups. So then there's from surveillance, then there's just usually just some surveys as such. So we can send out a survey to a group of people and ask, do you have this problem? Or how often do you go to the doctor for a particular problem? Or how much smoking do you have? Or do you smoke and drink at the same time? Now, mainly surveys don't link the cause and the effect very well. And it's a fairly weak study design, but it's a really nice one to have initially when you want to find out how big the problem is. If you're really looking at cause and effect, then you go for randomized controlled trials. Now, they're often used in health promotion interventions. So Mosvale suggested mammograms. So in the early days, when I was first training in epidemiology, we actually had randomized controlled trials of women into mammograms versus self-breast examination to look at which ones worked well. Nowadays you wouldn't be able to do that because it's unethical. So you know, we often use before and after study design, so before the intervention's rolled out and after. The other really good one for causation, cause and effect, is a cohort. So a group of people who have not got lung cancer, and I wonder if we can show the nice pictures of lung cancer here. So this one here is TB and this is lung cancer. You may not have seen a normal lung, but they certainly don't look like this. You'd know that it was usually, this of course has been put in formalin. Nevertheless, you can tell that it's not a healthy lung. So we might take a group of people, they often do this in the Netherlands and countries overseas where they can easily follow the population, and test them to make sure they don't have their disease of interest first, so they don't have lung cancer. Follow them through for 10, 15, 20 years and have them regularly reviewed by a medical or a research team to see how much they drink, any other lifestyle factors, and then follow them through until some of them get cancer and some don't. We also use case control studies, so we can start right at the end where everybody, we know a bunch of people have lung cancer, we get it from the register, and then we match them for similar age groups and what we call confounders, other things that can cause lung cancer, but we're not interested in that. We're just interested in the relationship between smoking and lung cancer, and that's called a case control. Case of lung cancer with a control, and then we ask them how much smoking they had. Now, within all of those study designs, the epidemiological tools, there are rates of disease that we measure that are appropriate for those. So incidence, so new cases would be for randomized controlled trials and cohorts, and prevalence would be used for surveys. Now the reason that we look at prevalence is that, for example, people have asthma, brand new cases, and then we'll have cases that are ongoing. And we'll want to have a look at the difference between new cases being diagnosed versus cases that need health services. So it gives you a burden, a much bigger number. And I don't know if you've learnt about the difference between incidence and prevalence, but where incidence and prevalence are not the same, where the burden of disease, the disease takes longer to get, for you to get better, or you take longer to die. So prevalence will be much bigger. If you die quickly and you get the disease quickly, then they're often matched similarly. Okay, so we collect data, and we usually collect data in epidemiology in big communities, and we look at health status, we look at social determinants and risk factors. Now, social determinants can be risk factors as well. Now, when I talk about social determinants, does anybody have an idea of what I'm meaning by the term social determinants? Okay, we've got 3 schools here, and you're all from different areas. Now, you're all very sort of middle class, and you're all eating very well. And your parents probably have jobs and can afford to put good food on the table. But some social determinants such as poverty can then impact and become a risk factor for disease. So we often measure social determinants every time we do a survey or every time we collect data on somebody. Now, we know that cases of cancer go to a registry, and we will also collect on that registry where you live, because we think we need to plot, are there more cases of a particular disease in a particular area, and therefore do they need a special intervention? Can anybody think of a social determinant and a disease that might help public health people to put in an intervention?
Well, could you say cardiovascular disease in a rural and remote area?
Yeah. Now, the 2 reasons that you'd want to look at rural and remote areas for cardiovascular disease versus, say, urban area is, 1, are we giving you in rural areas enough health services? So do we offer enough health services? Do you need flying doctors, or do you need a clinic opened once a week, once a month, once every 6 months, once every 2 months? So we look at utilisation. But we then might then say there's no direct cause and effect by where you live, either urban or remote, and cardiovascular disease. But we might then say, gosh, we need to look at risk factors because there could be something going on. Okay? So a social determinant could be a proxy for other risk factors, and it often helps us to zero in on where we might need to go. Imagine we collect a whole bunch of data on breast cancer. Now at one stage they were collecting breast cancer and postcode, and they found women that lived on the lower North Shore in Sydney supposedly had a greater rate of breast cancer than women that lived elsewhere. Now, this isn't my area of expertise, but let's just say that that was still the case today. Why do you think that? What do you think that could be telling you, and what other variables might you want to collect?
Well, that would be because due to the lifestyle choices of the people that live in that area, because it's the North Shore.
Yeah, lovely. Okay, so social determinants can be proxy for a lifestyle factor. It could also be that women in the lower North Shore who have more money to spend on health may be getting screened more. So are these newer, earlier cases, or so are we matching the same with the same thing? I mean, there's breast cancer in the later stages, and there's breast cancer that is found in the early stages. And so women with more money might actually get it in the earlier stages. But yes, it could be a lifestyle factor. So there was a discussion, just a discussion, that maybe women in the North Shore had some sort of ecological exposure than other women did. That could be one thing, or it could be a lifestyle such as maybe they have more dairy products, more lovely brie and camembert. Maybe there's something in their diet that they have more calories or something. So we always like to look at potentially the impact of social determinants. So this is where we routinely collect some of our data. So the Australian Bureau of Statistics, they do a 5-year knock on your door. And you know, if you've done one, I think it was just last year, you know, there are lots and lots of pages to fill out, but it's really important that you do. Australian Institute of Health also gives lovely data on admissions and the most common diseases that are admitted into hospital and cared for. The cancer register certainly is important. Every cancer that gets diagnosed has to be registered. It's the law. We get federal and government data from Medicare and specific hospital admissions, and we get lovely data also from MBF, HCF, that sort of thing for claims as well. This is a lovely table. Now it talks about tuberculosis, so you've seen a sample of tuberculosis, and new cases. So new cases, that means incidence, newly diagnosed. Crude incident rate means that it hasn't been adjusted for other possible, what we call confounders, or other possible causes. So we've got it now stratified by New South Wales, Victoria, Queensland, so by state and territory. So it tells us at the moment that the rate of TB in the Indigenous population is 3.1. Is there any other variable that you'd like the rates to be examined by?
Could you talk about you can divide it further into age groups and determinants, whether it be social or?
Thank you. Okay, so age and gender, age and sex. So at the moment it's crude, but it's not adjusted for age and sex. Okay, so we have here interesting data. Northern Territory's incidence of TB is 27.9. That's enormously huge. So immediately we start to be worrying and comparing it to, say, Tasmania or say New South Wales. But it doesn't tell us a lot about age, and we know that TB is a slow disease that takes a while Now this one is now new cases, and it's age specific. We often call that adjusted. Unfortunately, it's not adjusted by state. So this is just all of Australia, unfortunately. So now we can actually see where the burden of these new cases of TB are expressing themselves. And as you can see, the older you get, the more likely you are of getting TB if you're an Indigenous. So as a group of people, if you were going to use this for planning, what would you be doing about the Indigenous population, the elderly ones, or what would you be doing for the young ones before they get old?
Yeah, would that be having more access to health services?
Okay, so they need health services. So now they've got it, they need health services. What would you do for prevention? In public health, we often like to not just describe how big the problem is and give a health service answer. We often like to go way back and then say, how can we stop this from ever happening again? So what would you be doing?
Yeah, would you do screening and then immunisation?
Look, you can, yeah.
When they're younger?
Yeah, you could do
Or
it.
living conditions?
Yeah, well, look, it tells you that the older that you are, the greater the risk of getting it, so it does take a while. We also know about TB that certainly living conditions, and we can see the difference between the Indigenous and the non-Indigenous population. And we would then say, gosh, with TB, you need to live closely together for you to get the disease. It's a long incubation. And it's often due to, people often get it when they are undernourished as well. So there's a lot of social factors behind these numbers. So you could then go back and say, well, you might want to vaccinate a population first, so that you can then be working on improving those other social determinants, okay? So we've got those data, and then we would use them for example, all these sort of areas, which you've probably got in your textbook, so we won't take too long, but there's health planning and health services, so flying doctor service, planning clinics, how many paediatricians you might need, how many psychiatrists you might need, the public health programs that might be needed, such as vaccination for TB in the top end of the country. We also use it for clinical assistance, for developing evidence-based medicine. We use it for education, so we might know that we might need more doctors, nurses and allied healthcare professionals as well in all of Australia, or that in certain states and territories. Governments and non-government organisations use it to develop policies as well. Remember one policy about hepatitis. Now, hepatitis B, about 19-20 years ago, we were having an influx of migrants that were coming from countries that had a big burden of hepatitis B. So the government decided, when they looked at the numbers, they needed a policy that said children and families that come from high-risk areas can be vaccinated, because we couldn't afford a full rollout. Then they decided the vaccine was so sensible. I mean, all healthcare workers have to be vaccinated. We know that. They were at great risk. So then it became a rollout to the rest of the country. So then they decided that they could afford, and it was also well tolerated by the community. So that was a fine policy that they eventually, public health policy that will work very well in Australia. So can anybody list a couple of health promotion policies? Common ones that you use every day as young adults.
Oh yeah, could you just use the common ones like slip, slop, slap? That's probably the best known one.
Exactly. Slip, slap, slop you should be wearing every day, and your school would enforce, no hat, no play. Or they give you shaded areas. So that has been a public health policy that they found. Skin cancer, they know how long it takes to get. They also know how often if you're burnt, if your skin is burnt from the sun, what increase that does, that increase that risk for eventually getting melanomas. So they decided to develop this intervention, and it works brilliantly. Okay, what can go wrong with studies? There are many limitations. So we can sometimes collect too few observations, and that increases what we call random error. So if I did a survey of you guys and asked you how many of you had seasonal flu vaccine, I could then underestimate or overestimate how many young adults are vaccinated seasonally, because there's very few of you. If I increased my sample size to all young adults at high school in New South Wales, then I might get a more accurate picture, because I'm reducing the impact of random error. So we can also have too short a follow-up period. So some diseases take 10, 15, 20 years to develop. And if we collect data, particularly after an intervention, and we don't follow it for long enough to see how well we're going with that intervention, we can make erroneous conclusions that it's been highly successful. I just want to introduce you to a different type of epidemiology, because I'm hoping that you'll see that it's not all dry numbers. It can be really exciting. This is Lord John Snow, Dr. Snow, but he then was knighted. He was born in 1813 and died in 1858, and he's my hero. He's very famous for the Broad Street pump cholera outbreak. Anyway, there was a cholera outbreak in 1848, and 15,000 people died. Dr. Snow took a very detailed information, including where you lived and where you got your water. Now, South Walk and Vauxhall were one group of people that sold water and got water from the river. And the problem was that the river was full of excrement. In those days, there was no electricity, no plumbing, no pipes, no drain pipes, and private companies used to deliver the water to households. Some of them used to actually use a pump to pump the water up in the wells in the village. Lord Snow developed what we call a spot map. So here he's using the social determinant of where you live, and each dot represents the outbreak of cholera. Now, we use the same thing in the SARS outbreak in Beijing. So between the 8th of March and the 28th of March, poor old Beijing suffered the majority of the 5,327 cases of SARS. They had nearly 5,000 cases of SARS, and that's the beautiful square in Beijing. Epidemiologists always plot and always describe an outbreak by time, that's date and time, of everyone as they develop their signs and symptoms. We developed a spot map, so as you can see, they're the rates in certain areas. The city east, where the rate was 40.5 per 100,000 population, city west 44.1, versus way up there in Miyan at 1.2. So that tells the planners and the epidemiologists to rush out into the centre of the city and do something about it, such as quarantining.